Hi, this is Professor Stanley, and I am back with part 2 of our assessment of the neurological system. If you'll remember last time in the last video, we looked at how you could collect a very thorough history on your patient. And when you did, and a patient identified a problem in a certain area, that was going to trigger a very thorough questioning response to get to the bottom of exactly what is going on. We also looked at how to test the cranial nerves and the first part of assessing the motor system, which we will continue in this part of the video series. Now, I wanted to go back and recapture something that is very basic and probably will be conducted on every single person that you assess, and that is a mental status exam that will at least consist of whether or not a patient is awake, alert, and oriented. So let's begin with the first A. What does it mean to be awake? A patient who is awake is someone who is either easily aroused from a sleep state or is already present with their eyes open. Now let's continue to the second A, which is what does it mean to be alert? When you are charting that a patient is alert, you are deciding whether or not they are fully aroused and aware of their environment and themselves. While we may be able to tell whether or not a patient is awake and alert without a full conversation, in order to assess orientation, we are going to have to actually talk to the patient. First, you may want to begin by asking them their own full name. This will tell you whether or not they are oriented to self, and you might even ask, do you know who I am? Then you would know that they were oriented to others as well. You might ask them their present location to see if they are oriented to place, and the date to see if they are oriented to time. If they respond with correct answers, they are fully oriented. If they know their name, again, that is oriented to self. If they can identify you as their nurse, that would be oriented to others. So remember, when you are charting this, the first A is going to stand for awake, the second A for alert, and the O for oriented. So only chart A and A if the patient is awake and alert. And when you are charting oriented, you will follow it by using an X as like a time sign, and you will say 1 if they are only oriented to either person, place, or time, a 2 for 2 of those, and a 3 for 3 of them. So a person who is AAO times 3 is awake, alert, oriented to person, to place, and to time. And these terms are going to be frequently used in any setting you may be working in. Now, other things that you may be assessing is how is their speech? Is their speech coherent? Is it fluent? Are they able to stay on the topic of conversation, or do they drift off to other conversations? What about memory? Can they tell you what they ate for breakfast? Or if you were to give them 3 words like ball, pencil, house, can 5 minutes later they repeat those back to you and remember what you said? This is a part of the mental status exam. What about mood and affect? Now, we are going to talk a little bit more about this later, but for now, it is really easy to assess whether or not it is congruent or incongruent. An example of this would be if a person is incongruent, are they talking about how their husband was killed in a car accident while laughing? This would be incongruent. Or are they tearful while telling you about their daughter's wedding? In that case, you may want to explore that further, but it could be a sign of incongruence, as opposed to a congruent affect where they're telling you about a wonderful time they had with their family on the 4th of July while they are smiling and laughing about the time they had. So let's move on and talk about more tests that are part of the comprehensive neurological assessment. Assessing cerebellar function is easy by asking the patient to do some different types of tests. One of these is the rapid alternating movement test. Ask the person to pat their knees with their both hands, to lift up their hands and turn the hands over and pat the knees with the backs of their hands. Then ask the person to do this faster and faster, and normally it would be done with equal turning and a quick and rhythmic pace. Now, what would be an abnormal finding would be a lack of coordination with slow, clumsy, and sloppy responses. And the term for this is dysdiadochokinesia. An alternative to this rapid alternating movement test is to ask the person to touch the thumb of each finger on the same hand, starting with the index finger, and then reverse direction. Normally, this can be done quickly and accurately. The next test for assessing cerebellar functioning is the finger-nose-finger test. With the person's eyes open, ask him or her to use the index finger to touch your finger and then touch their own nose. After a few times, move your finger to a different spot. The person's movements should be smooth and accurate. A problem is indicated when there is a lack of coordination with clumsy movement that overshoots the mark and occurs with cerebellar disorders and with alcohol intoxication. That is called dysmetria. Also, past pointing is a constant deviation to one side. Next, we can test the lower extremity coordination by asking the person to lie in a supine position and place the heel on the opposite knee and run it down the shin from knee to the ankle. Normally, the person will move the heel in a straight line down the shin. A lack of coordination or a heel that falls off the shin will occur when there is cerebellar disease. Now we are going to test gait and balance. Observe as the person walks 10 to 20 feet, turns, and returns to the starting point. Normally, the person should move with a sense of freedom. The gait should be smooth and rhythmic and effortless. The opposing arm swing is coordinated, the turns are smooth, and the step length is about 15 inches from heel to heel. Then ask the person to walk a straight line in a heel-to-toe fashion, which is called tandem walking. This decreases the base of support and will accentuate any problems that they have with coordination. Normally, the person can walk straight and stay balanced. Now, abnormal findings with these tests is if a person's gait is stiff, where it's got an immobile posture, or staggering or reeling, or they have a wide base of support, or there's a lack of arm swing, unequal rhythm of steps, or ataxia, which is uncoordinated or unsteady gait. These are abnormal findings. And if on the heel-to-toe test, they have a crooked line of walk, or they widen their base to maintain balance, or stagger and reel, this is going to be an abnormal finding. The next test that we are going to perform is the Romberg test. Ask the person to stand with their feet together and arms at their side. Once they are in a stable position, ask them to close their eyes and to hold that position and wait about 20 seconds. Now, during this time, you should stand very close to the person because if they start to fall, you definitely want to be able to catch them. I will let you know that normal findings are a person can maintain their posture and balance even without the visual orientation that is provided by having their eyes open. A positive Romberg sign, or an abnormal finding, is the loss of balance that occurs when they close their eyes. You eliminate that advantage of orientation with the eyes, which had a compensatory mechanism for sensory loss. And a positive Romberg sign occurs when there is cerebellar ataxia caused by things like multiple sclerosis and alcohol intoxication. The next part of the neurological system which we are going to assess is the patient's sensory system by asking them to identify various sensory stimuli to test for the intactness of the peripheral nerve fibers, the sensory tracts, and higher cortical discrimination. We can test pain by their ability to perceive a pinprick, and the book suggests that we break a tongue blade lengthwise and form a sharp point at one end and a dull point at the other end, and lightly applying either sharp or the dull end to the person's body in a random, unpredictable order, and asking them to say either sharp or dull depending upon the sensation felt. Now, a normal finding, of course, would be that they were able to identify it, but if they have absent pain or increased pain or decreased pain sensation, that's going to be an abnormal finding. We can also use a cotton ball, similar as to what we did on the face in the last video where we apply this wisp of cotton to the skin and have them tell us when they actually feel the sensation. Of course, we're going to do this in a random order at various sites throughout the body and at random intervals, and ask them to say now when they feel the sensation. Next, we may use a tuning fork over bony prominences on the body and ask the person to tell us when the vibration starts and when it stops. We also may look at their ability to perceive passive movement of the extremities. For example, we're testing kinesthesia by moving their toe up and down and asking them to identify which direction we have moved it in. As part of our sensory assessment, we will also assess fine touch parameters such as stereognosis, which is where we ask the person to close their eyes and place a familiar object in their hands, such as paperclip, key, coin, something of that nature, and ask them to identify it. Normally, the person will explore it with their fingers and correctly name it. However, if there's an inability to identify the object correctly, this is called a stereognosis, and it occurs in sensory cortex lesions that may occur with things like strokes. Another thing that we can do is called graphesthesia, and this is their ability to read a number by having it traced on their skin. So again, ask the person to close their eyes and use a blunt instrument, such as maybe a pen or a reflex hammer at the other end, and trace a simple digit or letter onto their palm and ask them to identify it. If they're unable to distinguish the number correctly, here again, this can indicate a lesion in the sensory cortex. Finally, we can test extinction by simultaneously touching both sides of the body at the same point on the body and asking the patient to state how many sensations are felt and where they are. Normally, both sensations should be felt, and the ability to recognize only one of the stimuli occurs with sensory cortex lesions. The last part of our thorough neuroassessment is to look at the stretch reflex or the deep tendon reflexes. Now, a reflex is an involuntary muscle contraction, and in order for the provider to test this, the limb should be relaxed and the muscle partially stretched, and then the provider will have an action of striking the tendon, which is by the use of their wrist, and it should be a brief and well-aimed blow, and the limb should bounce up promptly. Do not let the reflex hammer rest upon the tendon. We are going to practice this in class, so I have not done any videos on it because it would be difficult to simulate what you're going to be doing with this by just watching a video. Now, when you are checking reflexes, both sides of the body should be equal, and they are graded on a 4-point scale, with 4 being very brisk and 0 being absent. The book does warn that grading the DTRs is only within the context of the rest of the neurological examination, because even some healthy people may have diminished or very brisk reflexes. The reflexes we are going to test is the biceps, the triceps, the brachioradialis, the quadriceps, also known as knee jerk, the Achilles tendon, the clonus, and the plantar. Now, plantar is interesting because we're going to expect to see flexion of the toes and inversion and flexion of the forefoot, but in infancy there is dorsiflexion of the big toe and fanning of the toes, known as a positive Babinski sign, where the toes are upgoing. Now, this is a bad neurological sign when it occurs in adults. We will need a reflex hammer to perform most of these tests, except for the test for clonus and the Babinski reflex, which will require us to use the back of the reflex hammer. This concludes the segment of the full neurological assessment. I will post a short video that will tell you how to do a neuro recheck, because that will be required of you in many healthcare settings, and I want to make sure you know how to do one properly. I will also plan on going over some common abnormal findings or some definitions that you may find useful.